Thank you very much for reading that. That wasn't supposed to be all read, actually. Thank you for asking me again to give this talk to you on an update on Parkinson's disease. I think it says something different in the program. I forgot what it said. So when I made this talk yesterday, after coming off call for 2 weeks, I thought I would present more of an update on the knowledge of Parkinson's disease that exists today. Now, I didn't realize that I'm going to have to stand there to see my slides, so I'm going to do a double thing, click the slides on my machine at the same time as over there because there's no monitor here, so forgive me if I get this coordination wrong. So, let's start with a little bit of epidemiology. We need to know a little bit about what the terrain of Parkinson's disease is. In fact, in the last little while, as the knowledge of Parkinson's disease has increased, people ask, has the number of patients with Parkinson's disease increased in the population? And the general answer to that is no. We know very well that Parkinson's disease is pretty much the same as it has been for thousands of years in terms of the number of people that get Parkinson's, statistically speaking. On the other hand, because there are a lot more elderly people in the population, the incidence of Parkinson's disease has increased relative to that, but not absolute. So the mean age of onset of Parkinson's is about 65. There are about 1.5 to 1 men to women, and that graph diverges at the age of 80 or so, 75. Before that, men and women are generally equally affected, and gradually, as you age, more men get Parkinson's disease as compared to women. Why that is unknown at this point in time. So at the moment, what we say the prevalence, which means the number of people that actually exist with Parkinson's disease, is about 1%, and that's pretty high at 65. That means 1 in every 100 persons at the age of 65 will have Parkinson's disease. That's a fairly high prevalence of a disease compared to that. MS is much lower, it's 1 in 1,000, so 10 times higher Parkinson's disease. And as I said, as people get older, that incidence is going to, or that prevalence, is going to increase. The incidence has not changed, right? So the number of new cases per year has not changed. The prevalence, of course, is the total number of people in the population, and more the people that are alive at that age, the more the number of Parkinson's patients. Excuse me. The other interesting question people always ask is, what are the chances of inheriting Parkinson's disease? And currently, that ratio of what we call idiopathic Parkinson's disease, and you can see that, I think there's a pointer somewhere here, but I can't point to anything, so it doesn't matter. Yeah. So the number of idiopathic patients with Parkinson's disease versus genetic, as you can, that's not advancing at all, is it? Oh, there. Oh, okay. See, I got that wrong at the first slide. That's the first slide, by the way, that I've been speaking to. So the numbers are there. It's just, so the idiopathic Parkinson's disease, the first number, is 90 to 10. That means at the moment, only about 10% of patients with Parkinson's disease are felt to be on a genetic or inherited basis. Most of the patients that we see, 90% at the moment, are what we call idiopathic, which means they don't have a family history of Parkinson's disease and simply have the disease. There are obviously a variety of different ways Parkinson's disease presents. Oh, somebody's playing with that. Is it okay now? Great, perfect. Okay, so at the moment, what we try to do is try and categorize the phenotype, how a patient with Parkinson's disease looks. And if you look at that category, TD means tremor dominant. That means that about 8 to 10 years into disease, not at the beginning, that's why I teach my fellows, about 8 to 10 years into disease, the predominant symptom is still tremor, right? Still tremor. So tremor dominant doesn't mean that you begin with tremor, and that's not tremor dominance. Tremor dominance is that tremor remains the dominant symptoms well into the disease. How many years? We don't know, but I usually teach between 7 to 10 years. If patient still has predominantly tremor and the other symptoms are minimal, then that's a tremor dominant disease, and that's about 8 to 10% of the population of Parkinsonians that we see. Then the AKR, or the akinetic rigid, the stiff and slow symptom presentations. So patients are generally hypomimic, low volume of speech, shuffling of gait, those kind of things, the slow, stiff syndrome. About 26% of patients are predominantly like this, and then about 66% are mixed. They have tremor, they have stiffness, they have rigidity, they have balance difficulties, all of those other things. So as you can see, the graph is skewed towards what we call the works. Everything is on the dish, and you have all of the symptoms. reason that's important is because the tremor-dominant patients are felt to, those that are 8 to 10 years predominantly have tremor, are felt to progress slower. Why that is, again, is unknown, and that's certainly true in clinical practice. So if at that stage your stiffness, slowness, gait difficulty symptoms are minimal, then the chances of progression that we normally see at 15 and 20 years is much lower, but it's a small number of people. There are a couple of protective factors. So smoking reduces the risk of getting Parkinson's disease by 25%, and that's not because you die of lung cancer. That would certainly reduce the incidence of most things. But that's somehow related, and we don't understand this, maybe related to the fact that simply those people that are smokers have more dopamine neurons in their brain. I mean, it could be just that. It could be that there's something that is metabolized as you burn nicotine that causes protection, and people have gone on to do trials using nicotine patches and things which have not worked, so it's clearly not that. So most of us believe that it is to do with the physiology of smokers to begin with that protects them, and may have nothing to do with active smoking. So we don't promote smoking in our Parkinson's patients as part of the center's therapeutic suggestion to our patients. And high coffee consumption, but that's a U-shaped curve. What that means is that up to a certain point, drinking coffee does seem to reduce the onset, but beyond a certain point, it increases the risk. Again, we really have no idea why caffeine, and people have, again, looked at that. A friend of mine in Montreal has done some work with caffeine, trying to see if we can use that in terms of slowing down progression of disease, and there really hasn't been any convincing data there. Finally, in that epidemiology, and people ask these questions, which is why I always like to frame the talk with the terrain, as I say, of Parkinson's disease. Family history we talked about. So certainly if you have somebody that is an immediate family member, so if I have my father that has Parkinson's disease, or my uncle that has Parkinson's disease, or my son or daughter that has Parkinson's disease, then I have a higher risk of getting Parkinson's disease, higher than the incidence in the population of 0.3 and 4.4 that I've got up there. It's higher than that, but it is not something that we can predictively say genetically, saying that you've got a 25% higher risk, 50% higher risk, because the condition is not inherited that way. So the rule of thumb is that the younger the parent is when they get Parkinson's disease, the higher the chance that the child will get Parkinson's disease. So if I have got a family member that has Parkinson's, if my father, for example, had Parkinson's at 50, my risk of getting Parkinson's disease is slightly higher than if he got disease at 70, and it'll be practically zero if he got disease at 85. And the reason may very well be that chances are that I'm in the same environment. If my father's 45, chances are I'm still living at home. And these days, more and more so that's happening, despite our attempts to get rid of our kids. Sorry, that's inner voice, sorry. Came out, but at the same time, as longer duration of age, which means that kids are living longer, we are seeing that trend, and that's well shown in the epidemiology literature. Why that is not known. I mean, it may very well be, as I say, that the exposure that the parent has is a similar exposure to the child, and the younger the parent is, it doesn't necessarily mean that it's a genetic form. Obviously, younger onset are more likely to be genetic forms of Parkinson's disease. Also a pesticide history, head injury, but again, we know that these exposure histories have to be fairly significant. So if you bump your head on the kitchen cabinet, that's not head injury. You're not about to get Parkinson's disease at higher risk. Because of that, you need to have repeated injury, almost similar to what Muhammad Ali has, for example, where you've had repeated. That's why all of this work on concussion in football or hockey is important, because repeated head injury causes axonal injury, injury to the wiring in the brain, and that could put you at a higher risk for development of these kinds of neurodegenerative diseases. Okay, so then one other slide on clinical features and presentation. It's important, I've divided it into two, and I guess I have to do it this way. And as you can see, I've put the first three: rest, tremor, slow movement, and rigidity. At diagnosis, about 70%, that means that 30% don't have tremor at diagnosis. Almost everybody, by default, has to, clinically, to make criteria, have to have slowness of movement, whether it's facial expression, speech, walking, arm movement, any of those things. So slow movement, what we call body kind, and rigidity, which is examinations that we detect in the body part, neck, elbow, wrist, etc. So to make criteria for Parkinson's disease diagnosis, you can then right side of that figure and say tremor, stiffness, slowness, at least those three things have to be there. So if somebody comes to my clinic and only has a rest tremor, I tend to not tell them immediately that they have Parkinson's disease. I may even tell them that they do clinically, but they don't make criteria, and those kinds of things are discussed. Why? Because pathology has shown that unless you have those three, at least those three symptoms and signs on clinical history and examination, then the positive probability of diagnosing Parkinson's correctly is lower. Right, so if I simply have somebody with tremor and nothing else, then it is possible that they may not actually have Parkinson's disease. So we wait to have those motor symptoms develop significantly enough to be able to be confirmatory. Right? In this domain, I want to make one point, and that's mainly for physicians, but also for patients who may have had this experience, that we don't use levodopa treatment or levodopa challenge by giving somebody 1 tablet or 2 tablets of levodopa to diagnose their Parkinson's disease. That's not done, and that's not included in the criteria for diagnosis. So anybody that knows patients, family members, friends, where that has happened, they've been told that they've taken 1 day worth of levodopa and didn't respond, and so they don't have Parkinson's disease, needs to see some other doctor. Right. So then the reason to have those symptoms on top is they are the cardinal motor symptoms of Parkinson's disease. Below that, in the last little while, and this has become very, very important in our regimen, are what we call non-motor symptoms of Parkinson's disease. Why? Because loss of smell, fatigue, depression, something called REM behavior disorder, where a patient, or in this case, a person, would scream in the middle of the night, kick loudly, fling their arms, what we call acting out their dreams, because as you might know, in REM sleep, you're supposed to be paralyzed, not move, but these patients move around a lot. Those kinds of things, and constipation, may precede the diagnosis of Parkinson's disease by many years. So 30%, greater than 10 years, so mood, fatigue, loss of smell. Unfortunately, none of these are specific for Parkinson's, so you could have a loss of smell and have had exposure to something in your workplace that has just gotten rid of your smell cells. It may very well be that it's a benign smell loss. It could also lead to other neurodegenerative disease, so it's not specific for Parkinson's disease. But the reason that this is important is that if you now frame what is the risk of me getting Parkinson's disease question in that domain. Say you're somebody that is 64 years of age, sort of in that age group where you may get Parkinson's disease. You've lost your smell 4 or 5 years ago. There's a lot of fatigue, significant constipation. You have an aunt that has Parkinson's disease, and in the last year or two, you developed this REM behavior disorder. Now, that package has become quite loaded that if we had something that would prevent you from getting Parkinson's disease at that point in time, that's the kind of person you want to act on in terms of trying to save or prevent the progression of that condition. Many of us believe that by the time you have, and in those cases, the top 3 symptoms are not present. There's nothing detectable on clinical exam. You don't have the tremor, stiffness, etc. Just the bottom ones. So those people that have that bottom block, some or all of them, are now termed Parkinson's at-risk population. So the so-called PARS, Parkinson's at-risk syndrome. We call it a syndrome because it's a constellation of symptoms, but it's really not a clinical diagnosis. You can't say to somebody that you've got the loss of smell, fatigue, depression, REM behavior disorder, constipation disease, right? That's not an illness. So because of that, it's not really a syndrome, so we term it PARS. Why? Because a small proportion of these people have a higher chance of getting Parkinson's disease than the general population. So the terrain of Parkinson's disease has shifted such that we look at those people at risk, yet we don't make a diagnosis. Yeah? So for making a diagnosis of Parkinson's disease, you have to be above that red line. To be able to be considered as somebody that could be at risk, yes, you can be in that set below, although we don't make a diagnosis. Now, the final interesting thing about this is that almost everybody that gets that, well, not almost, everybody that has the upper level symptoms will at some point get all of the bottom level symptoms. Right? So those are also symptoms of Parkinson's disease, and in that domain we don't call them at risk because they already have the top as well. We call them the non-motor symptoms of Parkinson's disease. See what I mean? So now you have a playing field where there are people that belong only to the bottom, don't have the top. We don't make a diagnosis in them of Parkinson's disease, but we watch for those kinds of people. Then we have people who have the top, plus eventually get the bottom or may already have the bottom. Now that's the Parkinson's package. That's important as a framework because when we consider treatment and therapy for Parkinson's disease, we need to not only address the motor symptoms, but the ones below. So in early disease now, there are two aspects of treatment in early disease. One is this concept of protecting or saving or reducing the burden of progression of disease. A lot of work has been done with respect to that. The second is detecting other biomarkers. So you could say that constipation, loss of smell, et cetera, are somewhat symptomatic biomarkers, so early markers. So if I were to do your hemoglobin, hemoglobin is a marker for anemia. So if your hemoglobin is 100, you're anemic. It's a marker for anemia. You may have signs of fatigue. You may have reduced pigmentation or pinkness in your nail bed or your, well, we don't make a diagnosis of what your hemoglobin is until we do the test. So that's a biomarker of anemia. Similarly, in Parkinson's disease, people have looked and are continuing to look, especially in that risk cohort of what we would call biomarkers, right? So here so those are the two things we're going to talk about. How to save or protect maybe whatever has been done. And the bottom line is until now, we have not yet found a therapy that will slow down the progression of disease. A lot of work is being done on this. This one particular study, coenzyme Q10 study, which was a few years ago now, that I was one of the principal investigators for this very large multi-center study. Unfortunately, coenzyme Q10 didn't produce the neuroprotection. It's not surprising because the cells that are being affected in the brain have a multitude of pathways. So for example, coming to Waterloo this morning, I came via the back roads. Other people might have come through Tavistock. Some people came through on the 401, but all of us got to the same place. Right? So there are many ways of getting to that point. And so if we simply were to say, okay, well, the 401 is blocked, I can take some other road. Unfortunately, cellular degeneration or injury to the cell seems to have many pathways to death. And so if we block one pathway using one enzyme, it has other routes by which it gets to the same place. So what we really need to do is find why this process starts. And it's more than simply aging. We know that it's not simply aging, because I told you, we have younger people with Parkinson's disease, we have genetic Parkinson's disease. So it's not simply that as you get older, you become older. So that's not what this is. This is more than that. So unfortunately, single or one enzymatic or therapeutic intervention, be it coenzyme Q10 or whatever, has not yet been successful, but there have been attempts to try and do that. This is one of those studies. The second one, which has actually been, which has garnered, I was going to show you a graph actually as to the number of publications that have been coming out on exercise in Parkinson's disease. And you can see that between 1980 to 1990, 1990 to 2000, in the last 10 years, the number of papers in the literature on exercise in Parkinson's disease have gone up like this, exponentially. Not really because we have understood anything more, it's simply that a lot of people are publishing on this. Right? And the reason that this is important is because we're not actually telling people anything new. We're telling people that, oops, it's irritating. I have to do it twice, but anyway. The reason this is important is because exercise is good for everything, right? And so what kind of exercise would you do? Who should exercise? Are people that have never exercised suddenly going to start exercising? What level of achievement of their exercise is important for protection? None of this has been worked out yet. There's a lot of hype out there as to, well, my exercise program, if you exercise doing funky maneuvers of this or that or whatever, that you're going to be better. No, there's no data to show that any of those exercise routines are better than the others. So currently, what we tell people is that, yes, you need to exercise, but also exercising, sitting on the edge of your going, oh yeah, that feels really good, good. No, that's not exercise. That's just stretching, getting out of bed. So you really have to do an aggressive exercise program where you sweat, which means 15, 20 minutes of aerobic exercise. Could be yoga type stretching exercise, which brings sweat to your forehead, right? When you start, that might happen in 15 seconds. But as you get better at it, hopefully you'll be able to go 15, 20, 30 minutes of exercise. Now, I tell my Parkinson's patients to break up that exercise routine in 2 or 3 parts. So you do 10, 15 minutes in the morning, usually the time when you're going to have finished breakfast and you really have nothing to do and you're going to fall asleep for an hour. That's when you put in your exercise routine, right? And at 1 or 2 in the morning after lunch, again, you're sitting in front of TV and your head is knocking against the remote. That's when you want to exercise. right? Because that gives you that ability to increase your adrenaline level. At the same time, it gets you something to do at that period of time that is important for you. So an exercise program, reclining bike, light weights, yoga. People have done randomized trials of Tai Chi and many of these others. There was actually a paper recently published on comparing these non-standard, a variety of different ways of exercising. None of them were superior to any one of them. So likely there was a what's called a meta-analysis published just last month in Journal of American Journal of Rehabilitation, which showed that all forms of exercise are okay to be used. So there's nothing specific, and especially if somebody's charging you a lot of money to go to their program, it certainly is probably not as useful to do that, because then you have a placebo effect of feeling better because you paid for it. And that's not really what you want. You want actually to do the exercise. So recommendation is any exercise. And in fact, the interesting thing is that in early disease, there is anecdotal but reasonably interesting data that shows that within the first 1 to 3 years, vigorous routine exercise can produce motor benefits almost as good as levodopa, not later, but earlier on in the first 2-3 years. So we really encourage people to get into the practice of active exercising, right? Whether it's with a group or whether it's on your own, exercise that produces that. So out of all the neuroprotection literature at the moment, the most interesting is something that we've known probably since 5,000 years ago, is that exercise is good for you. Right? And that's what is proven true even in disease modification. So not just symptomatic improvement, but people feel that the response to drug also is better if you're exercising regularly. Again, the reasoning, biochemical reasoning behind that is not known to us, but it's worthwhile doing because it's largely free. Right? Okay. In the last 5 years, there's been, like I talked about smoking before, another interesting phenomena, and this may actually have to do with exercise, that's why I've put it in, which looks at anti-inflammatory use. So years ago, when I was in training, which was 20 some odd years ago, there was a lot of data coming out saying that Parkinson's might actually be a disease where inflammation is important in the brain, which means just like when you get a wound and you get an inflammatory response on your skin, well, the same thing may be happening in the brain. So you have damage to the brain cells, there's inflammation, inflammatory response in the brain, and that produces cascade in cell death. It may also, in the last little while, more data has come out in the last 3-4 years that shows that it allows transmission of disease from one cell to the next. What does that mean? That means a bad cell has bad stuff in it, it releases it, and then inflammatory cells take that and give it to the next neuron. So if I spill water on my table, then I take the tablecloth that's wet and stick it on the next table. Now you've got a wet table on that side, right? So because I'm the inflammatory cell, I promote that transfer. If I wasn't there, then that tablecloth would stay on my table. So all of this has been going on in the last 20 years. It's become a hot topic in the last little while of transmission of disease, and the inflammatory cells may be responsible for that transmission from one neuron to the next, almost like a neuron internally infecting the next neuron, although there is no infection in Parkinson's disease as far as we know. So with that as the background, obviously one interesting thought would be if we shifted our concentration treatment from just symptoms to stopping that inflammation, getting rid of the guy that transfers that tablecloth from one to the other, hey, well, maybe then we contain the disease, right? Makes sense. So people have looked retrospectively at large databases, which means gone back into the database, and these are tens of thousands of patients, and I've seen that those patients that regularly used ibuprofen, you can see the leftmost little graph, so what is below that horizontal line is good for you, right? So ibuprofen, not aspirin, not other anti-inflammatories like Mobicox and others, and certainly not Tylenol, ibuprofen usage seemed to be related to reduced onset of Parkinson's disease. So let's tie all of that together. It could very well be that I exercise a lot, so my body hurts, so I take ibuprofen, and hence I secondarily prevent that transmission from occurring, even though the disease has started maybe in me, I cut it short. So maybe anti-inflammatories should be used in the treatment of Parkinson's disease. So about 10, 12 years ago, maybe longer than that, 20 years ago, there was a big initiative from the National Institutes of Health to try and do studies of anti-inflammatories, but the problem with them is that it causes ulcers in your stomach. So you're looking at something that potentially has an anti-inflammatory role but causes significant secondary side effects. So there was a big consortium, et cetera, and that entire line of work largely has been abandoned for that reason, because it's too dangerous at this point in time to give non-steroidal anti-inflammatories. So that takes us to that second part of this early, which is biomarkers. What is it that people are looking at? And we're not going to go into the details of this, because that table is just to show you that there are lots of things people are looking at to try and identify. See how we put the terrain of those people that don't have the disease, but have, they feel like somebody that could be, that Parkinson's at risk. If I could now make a diagnosis early enough, and then if I put them on an exercise treadmill aggressively right from the start, maybe I can change the course of disease. Maybe in somebody that I'm not sure they have Parkinson's disease, as I said, only tremor, early in disease, only tremor. If I could diagnose their risk of getting other problems, say dementia, for example, early on, then that is a biomarker that I could potentially alter. So there's a lot of work that's been done in early disease to identify such things as biomarkers, maybe on an MRI scan, maybe in a blood test, maybe in a biopsy, et cetera. And a lot of that work has been done, and for 30, 40 years, we haven't been successful. In the last little while, a couple of them, this thing called EGF. Oh, God, this is irritating to me. Yeah. So this, now that I've got the right slide on there, you can see that age of onset, ApoA1, right? So these are just a list of what we call biomarkers that are being tested in the blood. This ApoA1 is a, quote, biomarker that people are looking at, saying that if somebody has a high or low ApoA1 level, maybe they have a higher or lower chance of getting dementia. Recently, a paper published by a friend of mine, Dr. Stewart, a friend of mine, Ron Postuma, has shown that if you have patients that have that REM behavior disorder and a couple of other symptoms that normally wouldn't even be related in our mind to Parkinson's disease, the risk of getting cognitive decline or dementia later on is much higher. Something we want to try and know now from a planning perspective or even intervention and therapy. So a biomarker like this ApoA1, which is a blood test, could potentially also be linked to something like this. So if I, for example, we know biomarkers in breast cancer, right? So a particular gene for breast cancer has a higher risk, so you might end up having a mastectomy a lot earlier than a lumpectomy if you are positive for that gene, right? So that kind of therapeutic intervention in early disease has become hot. And one of the things that, now I'm going to advance this first, has garnered over the last decade a lot of attention is uric acid, right? Uric acid is something that's increased in patients with gout, right? So people that have gout have a high uric acid level. But we've found in some of our work, and I've just listed in the bottom, this is from a review paper from a few years ago, a variety of different studies, including the atherosclerosis risk and community study, the Honolulu Heart Study, health professional, doesn't matter the names, but these are large studies with tens of thousands of people. So you're talking about something like 50, 60,000 people, not patients, that were followed in these studies for heart disease. And it's a big database where things were collected, like uric acid. Well, when you data mine, which means you go and look at that data, you find that those people that had higher uric acid levels had a lower chance of getting Parkinson's disease. We talked about smoking, we talked about anti-inflammatory use and uric acid. Anti-inflammatory use is not a biomarker, right? Smoking cannot be used as a biomarker, but maybe uric acid could be used as a biomarker. So in the last 5 years, 8 years, there's been a lot of interest in trying to identify those people. So here's a scenario. You're 47, you've got Parkinson's disease onset. Can we use a biomarker? Or you're somebody that has a family member that has Parkinson's disease and another family member, and you're at a higher risk, at risk. Can I now use your uric acid? Somebody's gone on to actually do a small study to try and increase the uric acid in patients to see if we could even push that higher in at-risk people, not patients, at risk. So the terrain of biomarkers of early intervention of neuroprotection is like this at this point in time. In early disease, this is pretty big stuff, because once you've got at later stages of Parkinson's disease, it's not something that would be of much use because you already have the diagnosis. There's no need for a biomarker. By the time you're 10 years into disease, there's not much left to neuroprotect, so neuroprotection is not really that useful. You should exercise at that point simply to maintain your health more than anything else. One new thing that we've done, and I always like to throw in a little bit of our work in the lab in the last little while, is to try and treat tremor of Parkinson's disease. Remember I said that a lot of people have tremor. So we've come up with a piece of software in our lab over the last 3 years to treat tremor of Parkinson's disease. It's one of the most difficult symptoms of Parkinson's disease to treat. Yet, as I said, 70% of patients with Parkinson's present with tremor. So this is a solution. This is one of my graduate students, Jack Lee. We've put sensors on the body parts that have that tremor. And then we've developed a way of understanding how much the wrist moves, how much the elbow, how much the shoulder moves, and inject botulinum toxin for treatment of tremor. Very successful. So if we actually look at this next graph, it shows you that the graph on the left, the 3 graphs on the left side are shoulder, elbow, and wrist. So the biggest one is the wrist, the middle one is the elbow, and the right side one is the shoulder. And you don't really need to know statistics to know that the tremor reduction is quite dramatic. So we've now done this in 25 patients with Parkinson's disease and followed them for 3 years in our lab, and are now quite routinely suggesting to our Parkinson patients that if they have tremor dominance, in the sense, not tremor dominant disease that we talked about, but tremor is a bothersome symptom to you, and in fact maybe one of the only bothersome symptoms to you, that we offer botulinum toxin treatment quite successfully to many of these patients before we put them on levodopa or any of the dopamine agonists. And it works quite well in many, many patients. So it's possible for 2-3 years you may not need levodopa at all. If your main symptom is tremor, we can treat that with toxin. Just a little plug for that wasn't the idea of today's talk, but what we've done amongst many things in our lab. So we move from early disease to mid-stage disease in terms of treatment, and just the new things. I'm not going to go over levodopa and agonists and those kind of things, which everybody probably knows, or doesn't know, then ask your physician. So just one slide on treatment of a specific symptom in the middle stage, which is wearing off. And dopamine agonists, which are Mirapax and ropinirole and those kinds of drugs, have a role to play. They've been around for 20 years now, so nothing new to talk about them in terms of the oral treatment of dopamine agonists, and the enzyme inhibitors. So dopamine agonists mimic what dopamine does, which means it behaves just like dopamine and binds to the receptors. Enzyme inhibitors are those drugs that prevent or slow down the breakdown of dopamine once it is there, available to you, so that it's around longer, right? So you basically buy groceries, eat half the loaf of bread, the other half goes in the fridge, and then you can eat it over time. Well, enzyme inhibitors are kind of like that fridge, which allows you to eat that bread over a longer period of time. So they stop the breakdown or reduce the breakdown speed of dopamine, and hence you effectively have, for a little longer, a few minutes, maybe 20, 30 minutes longer, the dopamine available to be used. I generally use a drug these days called Stalevo, which simplifies the use of this enzyme inhibitor because it's combined with levodopa. Obviously, these enzyme inhibitors have to be used along with levodopa, because if there's no dopamine, there's nothing to slow down, so it doesn't really matter. If you don't have the bread, you don't need the fridge. So that's that. The next is freezing of gait. We've done a significant amount of work in our lab in the last little while with gait freezing. And one of the cardinal mid-stage to later symptoms of Parkinson's disease is this freezing of gait. And the problem with freezing of gait is that it's not just the gait that's the problem, but it's the risk of development of falls. And fall prevention is huge in patients with Parkinson's and in other disorders as well. So we took a signal that existed in trials that had been done with a drug called razagiline or Azilect, and that signal in those trials was that in some patients, gait freezing might have improved using this drug razagiline. So in the last 3 years, we've done a very extensive kinematically based study. What does that mean? That means we studied using sensors on patients freezing of gait in their home and in our laboratory before and after giving them this drug razagiline. And that work, we've just about finished doing the analysis because it's a complicated set of data. And what we're seeing is that there's a clear group of patients. Some people actually got worse on the drug, but there's a clear profile of patients where the drug razagiline improved freezing of gait. So our next job as part of that data analysis is to finish understanding what that profile is. What is the profile of the type of freezing that a patient has that razagiline could help them? Because there was a small number, as I said, that worsened. However, it is still probably okay if somebody has freezing of gait to have the doctor treat you with razagiline just to give it a try. At worst, if you find that the symptoms have worsened, you can always stop the drug. But a group of patients in that cohort had a substantial improvement in their freezing of gait. So it's something that we are now not recommending, but using in our practice in treatment of freezing of gait. So that is a second symptom outside of the wearing off that is important in Parkinson's disease at that mid-stage. Okay, so what is new in terms of treatment in the domain of this wearing off dyskinesia fluctuation? There are 2 or 3 new things in the last little while that have come up. Rotigotine patch. So I'm not sure if anybody here is on this treatment or not, but in the last little while, one of the new advances has been the development and, in fact, marketing in Canada now. It has been available in Europe for quite a few years, of this thing called rotigotine, which is similar to the dopamine agonists that we take by mouth, like pramipexole and ropinirole. The advantage of this drug is that it's actually a 24-hour patch, and it comes in a variety of different strengths. You can see that the little patch is 2 milligrams all the way up to 8 milligrams over 24 hours. And this is a patch that you can put on whichever body part that you want. It does have to be moved, and so you have to move it from here to there, up the, well, not on the forehead, I suppose, but up here, somewhere else. In the region of your upper torso, where blood flow is reasonably good, it does cause some local reaction. We'll talk very briefly about that. And it's quite a good option. I've used it in the last little while in patients in that mid-stage where having to add another drug that you have to take 2-3 times a day, more than that, or increase your levodopa, could have an adjunct treatment with rotigotine. Now, just to step back one step, even in early disease, there is good data to show that rotigotine can be used for treatment of patients, not to avoid, but at least in the early stages, used in monotherapy, just the patch for treatment of Parkinson's disease, so before levodopa onset. So rotigotine can be used there in early disease and also in this mid-stage disease for those people that have those fluctuations. So I've used this in quite a few people, especially those patients that have nighttime symptoms. It has a value of not having to get up in the middle of the night to have to take your levodopa. So you could give somebody just even nighttime patch, and if they really don't want it during the day. But it is a 24-hour patch, so there really is no reason why you couldn't leave that on. Okay? And here's just a graphical representation. You don't need to read the text. I will tell you what's at the bottom because that's important. But as you can see, the serum level, this is a study, but I just wanted to show you the graph. The level of release of the drug is pretty smooth over that period of time, going from about 0.5 to 2. So as compared to taking something by mouth where you have peaks and valleys. So levodopa classically has that, right? It has a peak and a valley and a peak and a valley like this. When you have a 24-hour release patch, it gives you that smoother curve. We'll talk about another technology in a couple of minutes that also tries to achieve the same thing. This is not levodopa. This is a dopamine agonist. Everybody needs to know that this is not patch levodopa. So you can't replace your Cinemet by this because it's a different drug, right? So we get a lot of questions saying that, oh, I've heard about the levodopa patch. No, there's no levodopa patch, it's this. There is a study that we're about to start, probably in the next month and a half, of a levodopa puffer, which is quite interesting because, as you know, levodopa is absorbed predominantly, or actually entirely, in the jejunum, which is the small bowel. And there are lots of issues with respect to that absorption, protein, slowing down of motility and not absorption, et cetera. But this product is an inhaled form of levodopa because the lungs also absorb levodopa. They don't actively absorb levodopa like the intestine do, which means that you don't have specific carriers for the levodopa that takes it across the intestine, but it diffuses across the lung membrane. So we're just about to start that study. I have some concerns, obviously, with that study because of the fact that you don't know how much deposits in the mouth, and then you swallow it, and then it goes into. But they've done this company has done the early phase studies to show that, in fact, you do have serum levels of levodopa that increase after a puffer, and they've done all the pharmacokinetics. We're doing some of the pharmacokinetics as well but that's an interesting new product in terms of levodopa delivery outside of the GI tract that is I'm not sure it'll come to market if the trial is successful, of course, but we're just starting that trial. My hope is that our first patient will be in January. So this is the levodopa puffer study. With respect to the side effects of the patch, you can see in that second column, application site reaction, fatigue, dizziness, and headache, a little bit of nausea, et cetera. So, but application site reactions are the biggest, so that's why we tell patients to move from one site to the other, so that you don't get a local reaction all the time in that one spot. Most of my patients, I don't think, I've used it now probably in a couple of dozen patients. I have not had anybody that has come back saying that I can't tolerate it, the reaction is too bad. They do get a local inflammation, but it has a place in patients that have that need to have a 24-hour without interrupting their lifestyle early and in mid-stage disease. Right? Okay, so Dr. Stewart is going to, I think, talk about complications of dopaminergic therapy, I think. So I'm going to leave that, but I just had one slide just to complete the picture, because we talked about dopaminergic treatment, that motor fluctuations, dyskinesia, impulse control disorders, and nausea, hallucinations are quite common in all the drugs that we use for Parkinson's disease. There's not a single drug that doesn't have some version of this happen, whether it's levodopa, dopamine agonist, patch, whatever it is, you will have the risk of having all of these things occurring, either higher or lower in percentage, but they occur. So a time to onset of motor fluctuations, the ups and downs, 3 to 5 years. Dyskinesia, about 3 to 5 years. But you'll hear more about that in a minute. So the second new delivery system that is in mid-stage disease, not in late stage or end-stage disease of Parkinson's disease, is this program that has just started called intestinal duodopa. Now, this is not a patch, and it is still exactly the same as the levodopa that you're getting, Cinemet, except that this is delivered through a proprietary gel pack. So the gel is put into a pump. The pump is connected to a gastrostomy tube. And of course, I have to have the picture there before I talk about it. And there's that picture with the gastrostomy tube. I don't have the ability to point, but you can see where it goes into the stomach. And then there's a tube that goes all the way down through the intestine into the jejunum, right? So it's a percutaneous endoscopic jejunostomy. The jejunum is where the drug is absorbed. So you have a pump, a jejunostomy, and the pump gives you supposed to be 14, 16 hours, but you can use it for 24 hours, I suppose, depending on the clinician. Delivery, so at least at this point in time, approved throughout the day treatment of levodopa through the pump. Right? So if somebody's getting 8 and 10 times drug, I won't use it for somebody that's getting 4 times a day drug, because you take it by mouth and it works well. But in that mid-stage disease, and a selected group of patients who have a lot of fluctuations and find that taking it often, at 7 o'clock, 8, 9:30, 10, 11, 12:30, this kind of a treatment would allow that smooth delivery like the 24-hour patch, except through a gastrojejunostomy. It's a day procedure. Our first patient is coming up pretty soon in the next few weeks in London. It has been done in Europe for many years. It has just arrived in Canada over the last year or so, outside of some study things, and it's now going to be available through exceptional access. Once you've seen somebody like me, or in Toronto, there are other centers as well, where a movement disorder expert then goes through criteria to make sure that you meet those criteria for treatment with this particular form of therapy. So this is intestinal duodopa infusion. And as I said, it's a proprietary gel compound that comes in a cassette. Patients are, at this point, supposed to be off at nighttime, and at that time they may take an oral medication, or they can put a second cassette. We're not doing that at the moment. And it is not, I'd said it is not covered as yet, but that's incorrect. It is covered, and we got our first approval just recently, and at the moment it is still quite expensive. Right? And here's the little graph from one of the studies. Again, I put these figures up not because we want to go through the figure, but to show you that if you look at the graph which has circles, the circle one versus the square. The circle is the intestinal duodopa. The squares are the regular levodopa, carbidopa by mouth. You can see that the on time, the one that's green, the circle graph is higher than the square, and in fact the off time, which is what you want lower, is lower. The red lower than the square. So basically what we're trying to say is that you've got better on time, lesser off time, and the blue is on time with dyskinesia is pretty much similar on both of them. So this drug does allow you to get a smoother on, longer on, better on, and lesser off overall. So a selected group of patients, it would be worthwhile in considering this intestinal duodopa, and it's just come online, as I said, within the last months in our practices. I've actually, as I say, not titrated a patient yet, but should be pretty soon, okay? The side effect profiles of this particular intervention, as you can understand, can occur because of device insertion. So the topmost on the left at the top, that little square, is complication of device insertion, then abdominal pain, procedural pain, et cetera, which is there in that little box. But the key over here to see is that all of those collapse down at week 2, 3 to virtually nothing, right? So initially, obviously, you've had a surgical procedure. It's a day procedure as compared to DBS, which is not a day procedure, which we'll talk about briefly next. All of these side effects do go away pretty quickly, and it's generally a well-tolerated procedure. Obviously, the biggest risk from this, or the biggest potential complication, is that the tube gets plugged, because it is in your intestine. There are things going, you're eating and doing other things. And that was one of the things that did hamper the startup of this particular therapy in Canada, was because there were some problems with the tubing and it had to be resolved, et cetera. But in the last little while, that has been, but only experience in our hands will teach us. Other centers have had success, so I don't anticipate a big problem in initiating this program in those small group of patients that we're going to select. Okay. And so that brings us to the next topic of deep brain stimulation. I wanted to cover these few, and then we'll see how we're doing on time, if we have time for the last few slides or not. All right, so deep brain stimulation has been done for many years. We've done over 200 and some odd in London. It's not a new therapy, but it is new in the sense that only a small group of patients are done. Normally we do in London somewhere in the order of about 25 patients a year. We have 3 neurosurgeons doing the procedure. In the next 2.5 months, for example, we're doing 7 patients. So it is a procedure that's done quite regularly at our center. And it will improve the quantity of the on time. So if you've got an on, which means that you're really good, your disease symptoms are well controlled for half an hour in the morning, half an hour in late morning, et cetera, through the day, this will make it last all day. It will not improve the quality of the on. So if at your best on, you're able to go from this table to the end of that platform, then that's what it'll give you. So the key definition of who is a good candidate, unlike the duodopa pump, for this procedure is that the patient must have the on that meets their goal, right? So if the patient's goal is to get up and run a marathon and they've been in a wheelchair for 3 years and their levodopa is not producing that, we're not going to produce that with surgery, right? So it doesn't improve the quality of the on, right? It'll improve the quantity of the on time. It'll reduce the off time. It does help us reduce the medications quite a bit. Most patients have their drugs dropped by about 50%, right? Generally not helpful for speech, and in fact, in some cases, definitely it can worsen gait. So it's not a procedure that is benign. Surgery-related complications are pretty low, 2 to 3%. 4% in some hands, which include things such as infection and seizure, et cetera, right? And we've become a little more liberal. We used to have a cutoff at 70, but now we're doing some patients 75, as long as their cognition and our neuropsych testing is pristine. Why? Because the risk of cognitive decline, the older you are and have DBS, is higher at higher ages. So we really need somebody that has a great response to levodopa, hopefully younger the better, right? Has no cognitive issues at all, and their goals meet what we can deliver with levodopa, okay? So just one graph again to show that there was a study that was published called the Early STIM study. So most of us over the years have operated on patients 12 to 15 years into disease. This study looked at those patients that are in that mid-stage, which is why I put this slide in this mid-stage, which is 7 to 10 years into disease. And what this study showed, again, you don't need to look at anything else except the red versus blue, right? So the red is neurostimulation, the blue is medical therapy. In the upper graph, PDQ-39 on the left is Parkinson's disease quality of life. Lower is better, the score better. So you can see that neurostimulation produces a quality of life improvement that's substantially better than medical therapy at about 7 to 10 years into disease. And if you look at the bottom graph, all the up things are better, all the blue things, medical therapy, are not good. So everything, including the PDQ-39, if you look at you don't have to read, I'll read it out to you. Activities of daily living, emotional well-being, stigma, bodily discomfort, mobility, social support, cognition. If you look at all of them across the board, that mid-stage surgical intervention in selected patients that meet those criteria is all in the positive, whereas the best medical therapy is either neutral or below. Right? So surgical intervention is a really important consideration in that mid-stage disease, and we are aggressively doing that in most of our centers these days. Okay? Right. So how are we doing on time? No time? 10 minutes? Oh, okay. Oh, okay. Well, then that's great. So we can move into the last few slides on late-stage symptoms and management. You can see that I've talked so far about neuroprotection and saving neurons, biomarkers in early disease. Treatment of the motor symptoms, freezing of gait, fluctuation, dyskinesia, smoothing out the motor response, etc., in the middle stages. When it comes to the later stages of disease, and this is a debatable point of what is late-stage Parkinson's disease, and honestly, I'll tell you, there's no consensus on what is late stage. Simply means that the symptoms have progressed to a point where a lot of other things are going on. Well, that could be in 10 years. It could be at 25 years. So it doesn't tell you that if you've got 20 years of disease, you've got late-stage disease, because I've got a lot of patients who are doing really well at 20 years, and there should be, by time, late-stage disease. So that concept of late-stage disease is really not temporal, not dependent on time. It's dependent on the severity of the symptoms of disease. And hence, in late-stage disease, you will see that you're now not talking about, other than freezing and falls, you're not talking about any of the motor symptoms. You're talking about swallowing difficulty, anxiety, lightheadedness, and dizziness, drooling or siluria, urinary symptoms, mild cognitive impairment or MCI, dementia, sexual dysfunction. All of these things, where's the motor symptoms in all of this? Where's the tremor? Where's the stiffness? Where's the bradykinesia? All gone at this stage and replaced largely and collapsed into what we would call mobility, replaced largely by a lot of these later stage symptoms, which are not motor symptoms of Parkinson's disease. But look at the frequency. 90% freezing and falls at 15 years, 50% swallowing difficulty, 30% anxiety, 20% lightheaded. So these are not 1 and 2%. These are things that if you add them up cumulatively will have a significant impact on quality of life of patients. So as you transition from that early, very neuroprotection exercise, let's do this, to the middle stages, to the later stages of disease, the management of Parkinson's disease has to be tailored towards addressing these things, because there are treatments that are available. Often, as physicians and even as patients, Parkinson's disease gets labeled as a motor disorder, and so pain is not treated in Parkinson's disease, or anxiety is not, or depression is not, or sleep issues are not, because of the fact that that is not part and parcel of what is the criteria of Parkinson's, which is stiffness, slowness, rigidity, tremor, etc. Right? So that's why it's important to talk about these briefly, and I'm going to skip this one and go to, because of time, we'll just go through a couple of these and we can take questions about cognition and hallucinations later. That was that slide. So sleep disruption is a primary problem in Parkinson's disease, and in fact we know well that along with the motor symptoms that occur at nighttime, sleep itself needs to be treated. It's things like RBD that we talked about, that REM behavior disorder, or restless leg syndrome. These things need to be treated at nighttime differently than simply treating our patients with levodopa, right? So I never use those dopamine agonists at nighttime, except the patch, which is 24 hours, and only in those patients where I need nighttime motor symptoms to be primarily treated, right? I use Lyrica a lot these days for restless leg syndrome therapy because it does not have the side effects of keeping people awake like dopamine agonists, Mirapex, and others do. So I use a lot of Lyrica. And I stay away from drugs such as amitriptyline, nortriptyline at nighttime because of hallucinations. So sleep treatment is important, right, for Parkinson's patients. I use melatonin to start in many patients as a first-line therapy, 5 to 10 milligrams of melatonin. It does work off the counter. It works in many patients. Sometimes we use a drug called clonazepam, but it has to be prescribed. And that is used for that REM behavior screaming syndrome disorder. And many, many times I use a drug called mirtazapine or Remeron. It's a good choice at nighttime, low dose, 7.5 to 15 milligrams for sleep induction, also for reducing sleep anxiety. And there's a small amount of anecdotal data. It may even help tremor at nighttime. So that's not proven, but I use this mirtazapine. So melatonin, first-line treatment in many patients that I do use for sleep-related problems. Mirtazapine, and I'm staying away from some of those other things, and Lyrica for restless leg syndrome. So this is more for the doctors, but at the same time, I want you to be aware that these are the kinds of treatments that are available. Melatonin you can buy. The clonazepam, Lyricas, of course, have to be, and mirtazapine have to be prescribed. But sleep hygiene is crucial. In fact, we all know that if you don't sleep very well, I just came off 2 weeks of call and no sleep for 2 weeks. I can clearly tell that I don't know which side of my jacket to put on after that. So clearly, we know very well that cognitive impact is significant after sleep. In fact, a lot of people, that's why that early PARS risk slide that I showed you before looks at sleep as being a predictor almost of development of neurodegeneration. And a lot of people are interested in that sleep cycle dysregulation. Many years of sleep cycle dysregulation now scientists believe may be related to later on cognitive decline. So sleep and treatment of sleep is an important thing that we need to do in Parkinson's disease as well. Besides improving motor function during the daytime, you're just tired if you don't sleep. Okay? Nocturia, or nighttime getting up to the bathroom. Now here's another interruption of your sleep cycle. So you get up 5 times or 6 times to go to the bathroom. So far there has been very little in terms of treatment of this nocturia because most drugs that we use for treatment of this have a really bad effect on mental function. So memory and confusion and hallucinations. In the last little while, there's been a new drug that has come onto the market called Mirbatric. It's over there, mirabegron. Again, some of these names are meant for the physicians, but I'm telling you this because of the talk being on treatment of Parkinson's disease. And the advantage of using this mirabegron, it relaxes the bladder smooth muscle, is it doesn't have those side effects of hallucinations, confusion, et cetera, because it does not use that anticholinergic property that all of the other drugs that I've listed down below, the ditropan, Detrol, Vesicare, all of those drugs have that side effect, whereas this one, which is what is called a beta adrenergic agonist, does not have the side effect of producing those confusional states. So I have started using exclusively mirabegron as first-line treatment if it's covered for the patient for treatment of nocturia. The other drug that we've been using in the last little while is a drug called DDAVP, which is a long word. Desmopressin is the other name, desmopressin. And the advantage of desmopressin is the same in terms of not having those side effects of confusion. There was a study done years ago by a Canadian colleague of mine from Alberta that showed that it was useful, but people haven't been using it. But it does work. So my first-line treatment for bladder, and you can write these names down, is the mirabegron and desmopressin before all of these. So those of you that are on the ditropans and detrols and vesicares and they're having side effects, if you're tolerating it, that's okay. But if you're having side effects, then these drugs have, in the last year, been, in our practice, becoming first-line therapy for nocturia. In the last couple of slides now, mood. Okay, so we've talked about sleep. We've talked about nocturia, we're going to talk a little bit about mood. We know very well that mood and dopamine are intrinsically related. So it's quite likely that even early in disease, and there's good data on this, that before you even treat the motor symptoms, you treat the mood that has an impact on motor symptoms. And there's data to show that you may even want to begin in that early symptomatic phase that I talked about, but I didn't talk about mood there, with an antidepressant, anti-anxiety drug right at the start, even before you start levodopa therapy or other Parkinson's therapy. This is actually where exercise might help you, right? So it's quite possible that exercise elevates your mood and also gets you out of that phase by increasing the neurotransmitters in your brain. So you feel good, you feel fit, you feel better about yourself, and that mood elevation might have an indirect but important impact on motor function, right? So treatment of mood is very important, and the reason I highlight these things is because when patients go to their doctors for Parkinson's disease, you often end up talking about all the motor symptoms, and the doctors don't talk about the non-motor symptoms. It's become much more common now because the awareness is higher, but you need to discuss these things. Nocturia, my mood, my sleep, constipation. They're not things that Parkinson's doctors are traditionally expected to treat, but are important in the management of Parkinson's disease, not simply as allied symptoms, but intrinsic symptoms of the disease itself. Hence, I aggressively use drugs such as Cipralex if anxiety is a component, and mirtazapine, which I use in the older population, especially when sleep is an issue. So those two drugs are common in my practice. I do use Zoloft or sertraline occasionally, and Effexor, but I primarily use these things. The last point I'll make about mood is if mood is an important priority in the treatment of Parkinson's disease in yourself or a family member, then even going to a psychiatrist and getting that treated aggressively is an important part. And we have 2 psychiatrists that are part of my team, and one of them is coming to speak to you this afternoon, Dr. Amir Burhan, and he's intrinsic to our psychogeriatric, and I have many patients that I refer to him, the older population, because he does psychogeriatrics. So really important to have that psychiatrist liaison if needed, if your family physician or neurologist feel that this is slightly out of their league, and that happens to me many times when I'm out of my league in terms of treating the mood disorder, but crucial for treatment of Parkinson's disease. And constipation, the reason constipation is important is besides the fact that it is a disabling symptom sometimes in patients with Parkinson's disease, our drugs cause constipation. So levodopa commonly causes constipation. And finally, the reduced GI motility that occurs from constipation reduces efficacy and absorption of our levodopa. So if somebody has significant constipation, then I know that their drug is not moving fast enough. So reduction of levodopa absorption is an important side effect of this, which is why it has to be aggressively managed. So I use all of the usual things, such as the Thanacots and Ducosate sodium, those kinds of things, but also up to lactulose and even Peglite to get the bowels cleared so the bowels are moving to allow that absorption of the drug, because the last thing you want is that the pipes are filled with stool and the drug ain't getting absorbed. Right? So that's crucial and important in terms of treatment of these non-motor symptoms. One last set of slides, and this is again, I want to end with a little pitch of our work that we've done, and it's been published and fairly extensively used now. The second part of the study, the Parkinson's Society Canada was kind enough to fund us for the study, is gum chewing, right, for treatment of drooling. Gum chewing is extremely effective during the daytime. Obviously, you can't chew gum when you're asleep, but I wouldn't suggest that. But during the daytime, gum chewing is extremely effective in reducing drooling in a large proportion of people. For those that it's not useful, we have been doing for the last 20 years botulinum toxin injections in the parotid and submandibular gland, and we have quite a few people that we inject this toxin. There is anecdotal data that shows that in some people it works really well, and others it doesn't work very well. But I do suggest gum chewing, and we've actually shown that in our work. We were the group that has shown this, and there were 2 interesting things that we looked at. The reason that patients with Parkinson's disease drool is not because they have excessive saliva. In fact, most Parkinsonians have reduced salivary production. The reason that patients drool is because they don't swallow, right? So this swallow reflex that is there all the time. So if you sit there for 10 minutes and don't swallow, you'll drool, even if you don't have Parkinson's disease, because it pools, right? So how do you increase swallowing function? Well, gum chewing does that. And we showed that in this paper, which was published about 4 years ago, that if you look at the number of swallows, and that graph is fairly obvious, at baseline, the left-sided graph that shows that the number of swallows is very little. During gum chewing, look, that middle graph, the number of times people swallow. This is because swallowing is like a sensory trick, a stimulator that you have to do automatically swallow. It was like 8 times higher. Significant. You can look at that graph, it'll tell you between 4 to 5 swallows up to 20 swallows, right? So significant improvement in swallowing and reduction in drooling, right? In fact, the interesting thing about the study was, and we can skip that because the last slide is all I want to concentrate. The interesting thing about this, and you don't need to analyze the graph, but I'll tell you, is that even after the patients spit out their gum, and that was the study. We got patients to chew for 10 minutes, and we spit the gum out, and then still did swallow assessment because we had a little transducer on their throat here, and we could count. how many swallows. Up to 8 minutes, even up to 10 minutes, many patients continue to have significant increase in their swallow. So what I tell patients now is chew your gum for half an hour, for those people that's important, before your meal. Spit the gum out. During that time, you cut up your food and get it ready. Now you can eat your dinner without having the risk of choking. It's not zero, but certainly better because your swallow function and frequency have increased. Right? So this is almost like a rehab for your jaw and tongue. The other side benefits of gum chewing can be cleaning your teeth, getting your tongue to move, and all those other things. In fact, some of the patients that have chronically gone on to the second study that we've not published because we didn't have proper follow-up for many of the patients, they just got better, they didn't come back for follow-up, was that their production of speech improved. Right? Because the saliva in the mouth reduced, swallow function increased, so their ability to talk improved. We didn't objectively measure that, but anecdotal reports were there. So what I wanted to tell you today was that and this is sort of a haphazard talk in a way, because we could talk about one of the topics for the entire hour, is to give you this terrain of what Parkinson's disease today is. Motor symptoms, the at-risk syndrome, the early treatment, and what people have found as, or what people are working on as hints and guides to biomarkers to protection of progression of disease, including exercise. The middle stage disease where one old but sort of new, and two new things, which is the rotigotine patch and the duodopa pump, and DBS in that middle stage of disease, and the later stages of multitude of symptoms that exist, including such things such as constipation, mood, sleep, fatigue, etc., that have to be treated. As I said, each one of these is a talk in itself, but the therapeutics of Parkinson's disease has progressed or has been attacked in all of these domains. And we do that in London. People like Dwight Stewart, who are here, practice this way in terms of managing that entire package of Parkinson's disease. And that's what Parkinson's disease management today is. And I'll stop there. Thank you very much.